Okay, we are live and for another SJMC Cardiology Grand Rounds. Alan Tay, I'm just the gaffer here. I put my name there as gaffer. Okay. I would like to take you through just some housekeeping slides before I pass it on to the presenters and the cardiology team here. So, audio is okay? All right, fine. Thanks, Kellen. The interactive questions and answers are using Slido as usual. For those of you who have attended our previous sessions, please join us at slido.com. You scan this QR code, which will take you to Slido and to the Slido event. Or else, if you have the app or you're already on slido.com, you enter 14796 as the event code. Okay, so the Q&A will be using Slido. And in between the case presentations, the presenters will be having a few. So we hope this is the first time you're using quizzes, so we hope you'll work out well. But please feel free to participate in the quiz at the end of each case presented. Okay, and then you claim CBD points at the end of the talk. We should be able to display the QR code. Don't confuse the Slido QR code with the QR code for CBD points. It will be shown in the blank space here in the last slide. All right, so without further ado, I'm going to pass over to my colleagues. So, Dr. Choi, all yours. Oh, who's presenting? Oh, Dr. Jamala, sorry, Dr. Jamala, moderator. Over to you.
Thank you very much, Alan, for helping to organize and to help us organize this SJMC Cardiology Grand Round. We are already in Grand Round 5, and the presenter this time is Dr. Choi, who will present the next slide. This is Dr. Choi, and I'm the chairperson. The panelist is Dr. Ko and Dr. Navid, who is the newest recruit who joined the SJMC maybe about a month ago. All right, and the topic today is recurrent syncope, but not bradycardia, and it will be presented by Dr. Choi. Over to you, Dr. Choi.
Thank you, Dr. Jayamala. As usual, it's a privilege to be given the opportunity to present the case, especially with analysts like Syncope. So today's topic is about rather different, which is cases regarding recurrent syncope. However, it's not about bradycardia anymore. So before I start, I would like to always show a bit of a cartoon. This is a very nice cartoon that shows that in medicine it's always about learning, never-ending learning, and we must always dream big. So we should be like these two spiders trying to make a catch at the playground. And if they succeed, probably they will be fooled for a very long time. Okay, now moving on. Let's start with the case number 1. Case 1, Miss Jane. So Miss Jane is a woman with an unexplained syncope. She's 35 years old. She does not have any known medical illnesses before. And of course, the background check, family history, there's no sudden cardiac death. So one day, while driving, everything was normal. Seems fine until suddenly she feels a very unusual chest discomfort. So always, I would be panicked if I were her. So she decided to slow down the car, but unfortunately, she passed out too soon. Now that's a car. So she survived the crash, but left very puzzled. All she had was just a normal lunch and a glass of wine. What could be the problem? She's the wine. So what is actually happening to her? So that's a million-dollar question, I suppose.
So, sudden fainting while what are the likely cause? Dr. Navid, I'll pass it on to you to try to answer.
A very good afternoon, everyone. Thank you for participating in this webinar. So I take your word that you only had one glass of wine and not the whole bottle. So sudden fainting while driving. So most patients actually probably present in a less dramatic manner, but nonetheless, this can be potentially a lethal situation, such as in this case where the situation is dangerous not only to the patient, but also to those around her. So when a patient presents with syncope, we can broadly classify the causes. Can I have the next? Yeah, okay. So when a patient presents with syncope, we can
present the question first.
All right, okay.
Ask the
So
audience.
probably you can just open this up to the floor and later you can give your answers. What are the possible causes, right? You can have neurogenic, cardiogenic, neurocardiogenic, or all of the above, right?
Passing over to Ellen to come up with the Slido questions.
Okay, we are using the quiz. Start the quiz or press.
Okay. So you can vote now. The answer.
So, voting now. Ellen, are they ready to vote?
Yeah, it's activated.
One vote per vote, isn't it?
Yeah.
We'll give them 10 seconds.
Leaderboard copy. Wait.
All right, that's it.
Wait. Sorry. Go to quiz. Wait.
Okay, so a bit of a hang up there. Never mind.
Wait. Okay, sorry. Yeah.
So for those who did not get the question,
Still showing the quiz. Yeah. Only 2 votes so far. Yeah, I'll show the leaderboard later. I'm also learning how to show Slido quizzes.
The votes coming in.
Keep it coming. 9. Okay.
Okay, not bad. 9, 10. Okay, people are getting the hang of it, and so are we.
Yes.
Okay, so shall we
let's
end the quiz?
Yeah, of course there's no leaderboard yet because everyone just got 1, so the answers are those who got it correct are there. Anyway, we'll move on to the presentation. Yeah.
So basically, when a patient presents with syncope, we can broadly classify the causes into 4 major categories, which are cardiogenic, neurogenic, neurocardiogenic, and another one that we loosely classify as others. So let's go a little more in depth with the causes. So cardiogenic is basically related to abnormalities of the heart, which include arrhythmias and structural issues. Arrhythmias could include conditions that cause slowing of the heart rate, which we know as bradyarrhythmias, or conditions that increase the heart rate, such as ventricular tachycardia, atrial fibrillation, or supraventricular tachycardia, or usually known as SVT. As for structural issues, they include conditions such as aortic stenosis and hypertrophic obstructive cardiomyopathy, or HOCM, where there is a fixed cardiac output, and also conditions such as pulmonary embolism, where there is a perfusion mismatch. Neurogenic, of course, as the term implies, are conditions related to the brain, such as seizures, absent seizures, strokes. And as for neurocardiogenic, the most common is, of course, vasovagal syncope, right? And this can be actually situational, or it can also be due to carotid sinus hypersensitivity. As for others, this includes orthostatic or postural hypotension due to volume depletion, and can also be due to autonomic dysfunction, such as in conditions such as Parkinson's disease. Commonly, what we see is diabetes. Patients tell you they stand up suddenly, they feel a bit giddy, right? And other little rarer causes such as Frey-Drager syndrome. So these are, I think, basically the most common causes. So as for this patient, of course, we need to go through a detailed history, physical examination, and relevant tests before we can come to a definitive cause. So for that, I pass the session back to Dr. Choi.
Thank you for the very comprehensive slide, Dr. Navin.
You haven't answered yet as to what you haven't given the
So I
answer
guess,
to the Slido.
after all the explanation given, we all know the answer should be all of the above. So how's the poll like, Dr. Allen? Did most of them get it right?
Wait a minute. Have to go back to the quiz number 1.
So that was very comprehensive, leaving no stones unturned, Dr. Navin. So I guess this woman is in deep trouble now, looking at a long list of possibilities.
Yeah, I think we will show the leaderboard in the end, but I think these are
Okay, no problem.
All right,
participants here.
doesn't matter. We carry on first, in the interest of time.
So no problem. Anyway, for my patient, so for her, the initial workup of for syncope, of course, a very detailed history taking. It goes all the way to the Mafia style, and a very thorough physical examination. And of course, this also includes lying and standing BP. If you've been following our grand ward round, you probably remember Dr. Yap's and Dr. Kannan's presentation, where if you check the patient, you always have to remember checking the blood pressure, not just in a sitting position, but also sometimes a standing position as well. Because some cases you will realize the orthostatic postural drop can be quite significant because of the decrease in venous return when you stand the patient up. And this could also be one of the possible causes for orthostatic related syncope. And for my patient, Miss Jane, initially saw a neurologist, which is something conceivable to do when you have a syncope. And CT brain, MRI brain, and EEG was actually done, and both of them were normal. Patient was then referred to SJMC, and she got a cardiology consult. So,
Okay, Cole, maybe I will ask you at this stage. What investigation would you do in this lady to exclude a cardiac cause?
So you have seen Dr. Navin's presentation. So the cardiogenic cause mainly divided into arrhythmia causes and mechanical causes. Those are the main causes for cardiac condition that can cause syncope. So for the baseline investigation, I will probably do at least an ECG. That will sometimes tell us whether there's any presence of left ventricular hypertrophy. You can see the LDH pattern, high voltage on the ECG. Okay, sometimes you can see already from the beginning there's a complete heart block, meaning there's a bradycardia, either complete heart block or either there's a sinus bradycardia. Or sometimes you can see already a tachycardia during presentation. I've seen a few patients that came to my clinic with a tachycardia, and then it shows the ventricular tachycardia, sometimes the SVT. Or if you're able to get the diagnosis of missed beat, sometimes what we do when we do an ECG on the patient, we wait for a while, because sometimes we have to wait until it captures extra beats, either a PVC, we call it premature ventricular beat, or a premature atrial beat. Then you will probably know that this patient is probably suffering from a missed beat due to a premature ventricular atrial beat. Then of course, these are all just a single time ECG, only captured for this moment. You might need to do a 24-hour Holter monitoring just to capture any silent arrhythmias. And I will usually do a stress test, not to particularly look at ischemia, but probably look at any stress-related arrhythmias. For example, stress-related or stress-related ventricular tachycardia, or even stress-related the induced heart block or bradycardia. Then the baseline imaging to make sure there's no structural heart abnormalities, like discussed by Dr. Navin earlier, it will be the echocardiogram to make sure there's no hypertrophic cardiomyopathy. As you all know, it's one of the most common cause of death in the US for young athletes, and also aortic stenosis, especially in elderly patients, and make sure the heart function is okay. So in general, if the patient has syncope and the heart function appears to be normal, that's basically at least you know that it's not in the high risk group. All right, so those are the basic investigation. Other probably optional, you may want to do like CT scan of the coronary and make sure there's no severe coronary stenosis. And I think that's my basic investigation that I'll do.
All right, okay, Troy, what did you do for this week?
So yeah, I totally agree with Dr. Cole. So I guess we might take a like in a way. So well, I start off with the the usual blood workup. So normal electrolytes for her, the potassium is normal, calcium is normal, sugar level is normal, blood pressure seemed to be okay, either sitting or standing, and her heart rate was seemingly low when we palpated her pulse. So now this is very interesting because you know, a lot of people will say, oh, the heart rate is about 45, or you are having sinus bradycardia, you're having just bradycardia. This must be another bradycardic related syncope. So I'd like to probably bring everybody's interest, attention to this bradycardia paradox. So what is bradycardia paradox? Maybe if I were to put up the ECG on the next slide, you'll be very interesting, I would say, for everybody. And I would like to maybe pass it to the moderator.
Okay, cool. This is an interesting ECG. You want to comment upon the ECG before we pass them to a Slido, please?
Okay. So I will comment a bit, but I wouldn't reveal the answer just to help out those who are looking at this ECG. Are we seeing the ECG? Okay. Let's look at this ECG first. Take a moment. Now, most of us are familiar with the sinus rhythm ECG. So as you can see, there's a tiny bump which is called the P wave, followed by a QRS complexus. So that is the sinus rhythm ECG. But in between, what we can observe is there is no P wave, there is no tiny bump. Instead, you get a very fat, ugly looking kind of complexus, the QRS complexus, more than 120 milliseconds in duration. This is called a broad complex extra beat that comes earlier than the expected sinus rhythm. Hence, this is something we call a premature beat. Do we have I've given a lot of clues already. Do we have, what was the poll? The poll is
Question
after that.
following.
Oh, the poll is after that, huh? Okay, anyway, so I think you all know that whenever you have a broad complex, it is originated most likely from the ventricle, all right? Because in the sinus rhythm, you depolarize the heart, the ventricle, from the center, which is the East Purkinje system, whereby you capture both left and right ventricle at the same time. So the contraction is fast, the QRS duration is short. In a ventricle, most of the time it's either from the right side or the left side. The extra beat coming from either the right side, left side. It's going to depolarize the right side first, and then take the whole 6 times travel across the left side and contract. Hence, the duration is a bit longer. Then you see the broad or wide QRS. So this is ECG showing a ventricular ectopics or ventricular contraction. It comes prematurely before the next sinus rhythm. That's why we call it a premature ventricular complexus. Now, the question I think Choi showed later, where does this premature ventricular complexus coming from?
Slido, back to you, Alan, for Slido.
But not yet the question. Maybe just I want to echo Dr. Koh's comment. These are all PVC. So the reason why I talk about the bradycardia paradox is that sometimes when you have a PVC in an alternate beat, so what happens is when you palpate the patient's pulse, you will only be able to palpate the sinus beat because the PVC is so premature that it did not actually generate any cardiac output. So technically, you will feel that the patient is having bradycardia, but in actual fact, that's the time when the patient has the most PVC. So I call it the bradycardia paradox. And I will move on to the Slido question.
This is quite tough, but if you look at the ECG, I give you the clue. Just look at lead 2, 3, and AVF, then you're probably able to determine where the PVC is coming from.
Slido question, Alan? Three people are slowly answering.
it outflow tract? Is it apical, ventricular tachycardia? Is it particular VT? Or do you just want to give up and say it's not determinable? It's probably one of the most common types of PVCs that you do see in the clinic. I guess if you run a clinic.
Yeah, I think we stop the phone.
That is a good number for a start.
Right.
Okay, what's the leaderboard so far?
Oh,
Alan say answer first.
Okay, all right.
Okay.
Okay.
So I go to the next.
yes.
All right.
Okay. So let's look at the possible origin of the PVC. Now I got an illustration here. Can you see the diagram of the heart? Now just imagine this is the position of the heart, where you have a ECG lead, particularly just looking at the inferior lead, which is the lead 2, AVF, and lead 3. The right ventricle, which is highlighted in blue, this is the right ventricle. The outflow tract means that the heart is pumping out from the right ventricle, where it leads to the pulmonary vein. And the right ventricular apex is the one that is around below near the apical. Now the red side is the left ventricular ventricle, where joining the aorta will be the left ventricular outflow tract, pumping out from the body. And from the apex, there's the apex at the below them. Now, if you have ectopic arises from the outflow tract, it will disperse from above to below, superiorly to inferiorly, right? Now, remember our basic of ECG, whatever electrical impulses that goes towards the lead will generate a positive deflection. So the lead 2, 3, and AVF all will be positive. Now, if the ectopics coming from the apical, it will disperse from inferiorly superiorly. So it's going away from the lead. Hence, you will get 2, 3 AVF to be negative. So from now onwards, when you see an ectopic in your ECG, this is something that you have to tell us whether in the 2, 3 AVF, the deflection is positive or negative. Now, if the deflection is positive, we know that this is the most common cause of PVC you will see, which is the outflow tract PVC. All right. So if you see something from the apex 2, 3 AVF negative, it is something very unusual, and most of the time you probably need further investigation. And sometimes it can be due to other problems like previous heart attack, structural heart abnormalities, heart failure, fibrosis, so on and so forth. So 2, 3 AVF negative is not something it is good. It's not a good PVC. Now, the third choice, the fascicular PVC, maybe we will discuss in a separate session, a long story, but to make it easier, fascicles means that the left bundle or the right bundle, and most of the time the PVC arises only from the left side of the heart, the left bundle. So if you have a PVC coming from the left side of the heart, the morphology of the PVC should be looking like a right bundle branch block. And in this ECG, you don't see a right bundle branch block kind of pattern, you see a left bundle branch block kind of pattern, meaning that this PVC is coming from most likely on the right side of the heart.
So I guess the answer is right. Outflow tract PVC.
Outflow tract PVC,
Yeah.
correct.
So 2, 3 and AVF is positive. It's a nice PVC.
Okay, Troy, so what other investigations? You have shown us the ECG. What other investigations did you do for this patient?
So for my patient, technically when we look at the cardiac workup, there's always a list of tests that we can always offer to the patient that we do have here in SJMC. So for instance, we can do stress test, echo, Holter, tube table, or even imaging. So let's talk about stress test and echo, because I have to stop at stress test because something interesting happened. First, the echocardiogram shows normal left, like what Dr. Koo mentioned about left ventricular ejection fraction is normal. It's very important. You have poor EF, obviously the VT might be different. No aortic stenosis, no hokum, features of hokum or kind of outward tract obstruction. So we did stress test. She's young, so I didn't subject her to do any CT scan to look at the coronaries. There was no real SD changes to indicate significant ischemia. However, at the end of the stress test during recovery, something interesting actually happened. She developed giddiness, and then she almost had a pre-syncopal attack. And this was the stress test during recovery. And it's not a gimmick because you can see supergiant medical center at the top of the stress test. It's a real patient. So this brings us to the next question. What does this stress test show? This will be our next Slido question. Is it A, does it show a ventricular fibrillation? Or is it B, a torsade de pointes? Or is it C, asystole, the worst kind of rhythm that you want to get in a stress test room? Or D, a non-sustained ventricular tachycardia? So you can move on to the Slido page and put in your votes. I'd like to know what you think. If you run a clinic, a GP center, and you have a patient with this kind of rhythm.
Click join the poll, then you are given the 4 options.
We have more than 10 this time.
Let's have more votes.
Okay, I think we can stop and move on.
Okay,
And only a bit more.
break the 10, break the number of 10. 10. We only 10 people watching.
11 votes.
All right.
Yeah, you may have problems because actually I realized the Slido, they will show that the new poll is there, but you have to click join to actually see the options. Yeah. Right. So anyway, 15 have voted.
Okay.
You want to see the leaderboard?
Yes, let's have a look at the leaderboard.
Oh,
Not easy to know.
Shirini is number 1. Okay.
All right.
All right. So as you can see, before we move to the next the answer, so this ECG, this strip shows fairly similar morphology type of PVC, and as how Dr. Ho has highlighted in details just now, it is obviously coming from the top, the 2-3 and AVM is positive. It's the same morphology, but it has gone into a run. So we call this ventricular tachycardia. And fortunately for her, this run actually terminated on its own. Of course, if it did not get terminated, and probably patient will develop another syncopal attack. So the answer is D, non-sustained ventricular tachycardia. So it's not ventricular fibrillation because the morphology is similar. It's still monomorphic. The same type of morphology. You can choose the first beat and you can choose the last beat. You can put them, you can switch them, and it will still look alike. So it's not ventricular fibrillation, and it's not torsade de pointes as well because that also means polymorphic VT, and obviously it's not asystole. So stress test with VT after exercise.
So, Cole, what are the possible causes for VT on exercise?
Okay. Do we have a poll for the audience after this? I mean, for this question, before I review the answer.
Unfortunately, no.
We have maximum 5 polls along.
Okay, so maybe you can show the next slide.
Okay, all right.
We do have, but this is not in the for the GPs, right? For the doctors who are doing online. So you can see that the possible causes, you can have audit A to E, but let me illustrate from a slide for you all that the post-stress test, when we look at a non-sustained VT, we probably look at whether is it what they call a monomorphic kind of VT or a polymorphic kind of VT. So I can move on to the next slide. So monomorphic is what Dr. Choi meant. The first morphology of the VT looks like the same as the last, means that single focus, single morphology, single pattern kind of VT. Polymorphic is it keep on changing. Some are negative deflection, some are positive deflection, some appears to be narrower, some appears to be broader, and sometimes you have this twisting point, which we call a torsade de pointes, particularly related to long VT. So polymorphic means that you see a lot of kind of VT morphology. So it's very important because the monomorphic VT only can happen in 2 conditions. Either you have a scar, I can show you an example. If you have a scar, for example, if somebody have a myocardial infarction, you have a scar in the heart. If you have a previous heart infection called myocarditis, you leave a scar. Or some condition called non-ischemic cardiomyopathy, basically a heart failure without known etiology, they will form a scar. And also a rhomogenic right ventricular cardiomyopathy, a very rare condition that the heart forms fatty tissue and a scar. Whenever you have a scar, you will probably form a circuit. High likelihood you will form a circuit. And this is a circuit that will trigger into a re-entry ventricular tachycardia. That's why it's monomorphic, because it only go in one place. Another condition is there is enhanced automaticity from a group of cardiac tissue, and most of these are idiopathic. And if you see a young person without structural heart abnormalities, then you will probably, high likelihood you will be dealing with this group of patients, idiopathic kind of disease. Next is a polymorphic. Polymorphic is a bit generally more dangerous because most of the time the common cause of polymorphic DP is due to ischemia. And you know that cardiac ischemia is the most common cause of death worldwide. Because of the multiple area of tissue ischemia, not only the endocardium, the epicardium also will get ischemia. Multiple area of ischemia, the right side, left side, proximal, distal. That's why you see this PVC coming from various parts of the tissue. And in a rare genetic condition like long QT syndrome, catecholaminergic polymorphic DP, they sometimes induce whenever you have increased adrenergic stimulation. So these are the basic things that we look. When you look at stress test, when the patient develops broad complex tachycardia, you have to tell us whether it is monomorphic or polymorphic DP. And if it is monomorphic, then you have to look at a baseline ECG again, this time wearing more thicker glasses, see whether there's any Q wave, there's any LVH pattern. Okay.
What additional tests would you do now?
Okay. So if I have done all the basic tests earlier, ECG, stress test, Holter, echocardiogram, and if I find something, of course I will probably investigate further. If I don't find anything, then the next test I will order the best bang for the buck would be, I think, cardiac MRI. Because why? Most of the scar tissue are subclinical, sometimes echo cannot pick up. So probably I will order a cardiac MRI, and perhaps later on we will do we call an electrophysiology study. This is an invasive test where we will determine what is wrong with the heart, where is the source of the problem, and how do we rectify this.
Yep. So I'm so glad that my patient is having monomorphic ventricular tachycardia, so that kind of rules out the polymorphic part. So I totally agree with Dr. Koh. I think we need to look at the scar, whether the patient has any scar in the heart. So we did a cardiac MRI and it's normal. Just to share with you all, so this is what it looks like in a normal cardiac MRI. If you look at this slide, this is left atrium, this is right ventricular outflow tract, and this is pulmonary artery. I want to show you an interesting slide. So this is almost alike, but if you look carefully, when you look at the right ventricular outflow tract, there seem to be some bulging areas over the outflow tract. So this is what we call right ventricular aneurysm. Like what Dr. Koh mentioned, this is one of the types of the ARVC. So in patients with ARVC, they can have normal ejection fraction. Everything seems to be normal, but they can have VTs, recurrent syncope. And finally, when you put the patient into the MRI machine, it comes out to be some kind of outflow tract aneurysm with some fat deposition. So this is abnormal and this is normal. So anyway, for my patient, the cardiac MRI is normal.
Tell us, what did you do with this patient?
So next, to recap, this patient has multiple runs of non-sustained VT. She had fainted before. To work out for the electrolytes, MRI, all normal. So I did put her on the beta blocker. Most of us will do that, I think. And I put her on the bisoprolol, 2.5 milligram daily. However, she's young. Her baseline BP was already low to begin with. So when you hit her heart with the 2.5 milligram of bisoprolol, usually what they experience giddiness. So from occasional giddiness to almost constantly daily giddiness. So I'm not sure whether that's actually therapeutic. So anyway, I want to quantify a little bit more on the PVC. So what I did was the Holter monitoring. I'm sure all of you are very familiar with Holter because we need to quantify the burden. We need to capture how long the non-sustained PVCs are. Were there any occasion where the patient developed ventricular fibrillation, polymorphic time, and also the overall heart rate variability? Holter, well, we used to have problems with the conventional Holter. So as you all remember, Holter is Holter used to be a very troublesome kind of pet. So you have to hang something around your neck, walk around with this tag, but a bit bulky, so many wires that keep you itchy the whole night. And sometimes your wife won't be very happy with that. So, just kidding. Anyway, wires, you can't shower, you start to smell the next day, and it's not very Instagram friendly. To do it more than 48 hours, I think it's a bit challenging. We can, I guess, but most of the patients will be very unhappy. So what could be the solution? So for my patient, I put him on this little Holter. Believe it or not, yes, it is true. So this tiny little thing is actually a Holter. Not only that it records up to 48 hours, it can go up to 14 days. And yes, there's no wires. You can shower finally. And most of us will believe that it is actually Instagram friendly. All right. So the result for the Holter for this patient, 30% of the PVC burden. Now that's very high. I think most of us have PVCs occasionally, but that's probably like less than 5%. This patient also has frequent non-sustained VT. And after you put everything in together, she has decided, like what Dr. Cole mentioned, one of the tests that we can do is electrophysiology study with a KIV radio frequency ablation. All right.
So tell us something about this EP study and how do you do radio frequency ablation of choice?
Okay, I'm so glad you asked, Dr. Demla. So just a bit about radio frequency ablation, also known as RFA, commonly known as RFA. So it's a procedure where the doctor will actually put in catheters into the heart. In simple terms, it's to target and destroy. So in this patient, most likely the ventricular tachycardia is coming from some kind of cells or tissues with automaticity. So in simple terms, I always tell the patients they have extra battery cells in the heart, and we're going to target and destroy these battery cells. So the treatment for arrhythmias like PVC, VT, AM, SVT can be used. Radiofrequency ablation as a treatment. It's typically done via percutaneous femoral access under local anesthesia with very minimal pain. And most of the time, we will do it together with a 3D mapping system for better precision and also reduction of X-ray. Once successfully ablated, the arrhythmia, tachyarrhythmia, will be rendered non-inducible, technically treated. So this patient was brought to Subang Jaya Medical Center Invasive Cath Lab, which is located at the 6th floor. Her RVOT was electrically mapped. Remember Dr. Cole's diagram, the outflow tract? So we actually mapped the right ventricular outflow tract, and we found the so-called automatic cells, the culprit. So the focus of the VT was successfully identified and ablated. So this is actually the diagram that you usually see once you map the patient. So this is the outflow tract on different views. This is RAO view and this is LAO view. If you look at the white dot over here, which is pointed out by the arrows, the white dot is actually where the focus is. So what you need to do is just go to the focus and ablate it. And if you look at an X-ray, most of the time you only need to use one catheter, and this is the ablation catheter fit on an X-ray. So for my patient, luckily for her, she survived the procedure because it comes with very minimal risk most of the time. She has no more symptoms. She has no more symptoms after that. No more palpitation, no more syncope, and we repeated the Holter. It's less than 1% of PVC.
You even look younger.
Yeah, in fact.
That's right. After the accident.
With a better smile. And someone told me it's a new lipstick. I'm not sure. So no more sustained VT recorded, and beta blocker was discontinued. I'd like to take a little bit more time to share. I'm sure Dr. Cole, Dr. Ravi, Dr. Naveen, and Dr. Jia will probably echo my thoughts. The concept of cure for arrhythmia. So, radiofrequency ablation is actually to minimize long-term pharmacological dependency. It comes with very low recurrence rate after a successful ablation. And the term cure, I hope I'm not overstepping people's toes, is possibly that. Cool. What do you think? Do you think can we term as a cure for arrhythmia in this kind of PVT?
Yeah, I agree. In fact, most of the arrhythmia we're able to achieve cure by means of ablation therapy. Yep.
So no more beta blockers, no more pills to lower down the BP and everything. Dependency on drugs, 35-year-old woman. I think it sounds quite convincing.
Okay. This sounds very interesting about cure. What other situations would you consider EP studies and radiofrequency ablation besides this particular case? Maybe I ask Cole.
Okay, for the general audience, maybe I will just give them an overview of what is the indications that we do EP study. Okay, basically we do EP study for two reasons. Number one, diagnostic, and number two, for therapeutic, and of course, some is be able to achieve curative. In diagnostic, let's say we have worked out patient with a suspected tachycardia. For example, patient with a lot of palpitation, however unable to capture with a non-invasive testing. For example, we have already put on a 24-hour Holter. A few times we are unable to capture it because sometimes the arrhythmia only comes like once in a blue moon. Or patient with a suspected bradycardia, for example, keep on having giddiness, and you suspect that possibility of having intermittent heart block or sinus node dysfunction. Again, you can't capture during a normal routine non-invasive testing. You put a 10 Holter, wasted all the money, you still cannot get it. Or some patient with a second degree AV block, you can see the second degree AV block in the ECG, like 2:1, for example. Most of the time, we won't do anything unless the patient is symptomatic, but the patient tells you that he has pain or giddiness, you are not too sure. Then these are the time where we can put in the EP catheters. Like Choi mentioned, we put on one catheter, but for EP studies, we put on 2 or 3 catheters. And we're able to induce tachycardia. We're able to induce sometimes a sick sinus of bradycardia in this group of patients. And then, of course, curative. Curative means that patient, like Dr. Choi's patient, already you know that there's a BP, you know that there's a PVC. So in general, we can ablate anything that moves in the heart. Yeah. So ventricular tachycardia, most of the idiopathic ventricular tachycardia, most of the supraventricular tachycardia, we're able to achieve cure in more than 90% of the cases. Atrial fibrillation is the one that probably at this moment in the world, we are unable to claim that we're able to achieve cure, but I would say that the success rate is still reasonable, 70 to 80% for those who presented very early with atrial fibrillation. Okay.
Okay.
So I mean, PVC and PAC is the one that is less. We do less, especially we only do especially when the patient complain a lot of symptoms or high burden of PVC. Sometimes can cause cardiomyopathy. Sometimes we will do some because all these patients they are very young, and they are when they take a bit of medication, the pressure drop, the heart rate become low, they become symptomatic. They are young, they are working age group, they cannot work, so that's why they come for us for ablation. So we relieve the symptoms.
So yeah, Troy.
Yeah. So again, like what Dr. Ko has mentioned, the reason why we chose radiofrequency ablation for this patient because early RFA can be considered for individuals who are symptomatic, high PVC burden, and of course some patients who have a failure of drug therapy.
Okay, we have about another slightly more than 10 minutes to talk about the second case, Troy. So maybe you would like to just quickly share with us the second case of Syncope.
Okay, so let's move on to the second case, which I promise you to be slightly even more exciting. So we had Mr. Scott, a young man, they have all very young patients, who had a terrible fall. So 21 years old, Mr. Scott, he again has no known medical illnesses, an active gentleman and plays badminton 3 times a week, more than me. Only play 3 times a year. One day, after an intense game of badminton, he felt different. He was standing by the badminton court, and started to feel a little bit dizzy. Vision started to blur out with a slight warm sensation over his face, and he fainted, and he suffered a knock on his head. Again, another syncope. He regained consciousness a few minutes later. There was no confusion or no weaknesses or any kind of neurological deficit. No memory loss as well. No eaten time marks can be seen. So now the question is, we did some workup for the patient. Electrolytes are normal, glucometer is normal, pressure is about 110 over 70. Heart rate this time is 60 beats per minute and it's regular, no bradycardia. So
Naveen, what do you think? You give us a whole lot of list of causes. What do you think is the likely cause in this patient?
Yeah. So again, we have a very young patient, very fit patient, plays badminton, and this is the first time he's had a syncopal attack. And Dr. Choi has provided some of the basic investigation done. So again, would anyone want to, you can start putting up your votes. So syncope after a badminton game, what is the most possible causes? Bearing in mind this is a fit 21-year-old. Sorry, maybe we can have the Slido again.
The most possible.
Yeah. So bearing in mind, like I said earlier, 21-year-old. So can it be an acute MI, pulmonary embolism, neurocardiogenic or vasovagal syncope, or just pure sadness after losing this game?
So make sure you're on the polls tab of Slido and then click the green join button. Then you see the options to vote.
They're getting more than 10.
I think people getting used to the system. Yeah.
That's right.
So
Okay. Okay,
So
so
we can
maybe we can
answer.
move on.
Yeah.
Yes, back to the answer.
Leaderboard. Nagaratnam, the fastest.
Oh, all right.
Okay.
So now we can move on to Dr. Choi here. Tell us how he clinched the diagnosis for this patient.
Yeah, so we probably leave the answer, right? This is the last one. Right? So what next? For this patient is young. The basic workup is actually normal. Electrolytes normal. I
assume his ECG was also normal. It was not an acute MI.
Correct. We have ruled out a couple of things. I think I missed out the slide where the ECG was normal. We also did some blood tests like the D-dimer, of course the echo to show no signs of massive pulmonary embolism and such. He's otherwise comfortable, not tachycardic. The pressure is normal. So anyway, after a long list of investigation, we actually subject the patient to this test called tube table testing. Some of you might have heard of a tube table test. So this is what it looks like. Just a bit of a description. So tube table test is used to evaluate the cause of unexplained fainting. So the keyword is unexplained. So if you have a pulmonary embolism or you had an acute myocardial infarction, it's called explained. So this is unexplained, like in my patient. So sad to say, you have to strap the patient to a bed, and the body position is repositioned from horizontal to a vertical, semi-vertical position. And you need two things. You need blood pressure monitoring, and it's not just the usual Dynamap blood pressure monitoring. You need a beat to beat. So every single beat generates a pressure, and we need to have a constant blood pressure monitoring, and also the heart rate, both being constantly monitored. Any drop in the blood pressure, which we usually use the term vasodepressor, dominant, or any pauses, cardio inhibitory, can give us a positive test. It can be done safely with very minimal risk. And I just want to show you our tube table, just to show that it can be quite comfortable to look at actually sometimes. So moving on.
What are the indications and contraindications for tube table testing? Cole, maybe you would like to tell us a bit more about this.
Okay, so we have a list of indication and contraindication. Let's show the list here. As you can see, there's a lot of words, but the indication in general, to make it very simple, is actually unexplained fainting episode. So again, unexplained fainting episode, you need to have a normal baseline, at least a stress test, ECG, Holter, or echocardiogram, make sure there's no structural heart abnormalities, and then you still cannot explain the fainting episode. Sometimes you may want to refer to your neurology colleague to make sure there is no neurological problem like seizure, epilepsy, this kind of thing. And you can look at the indication recurrent syncope or even a single episode accompanied by serious injury. So meaning that you don't want a person who has already fainted once and then involved in an accident to happen again, because he might not survive the second accident, or maybe the patient is in the occupational hazard, poses the occupational hazard, like for example pilot, commercial vehicle driver. You don't want your pilot to have unexplained fainting and then fly you to somewhere. And also a surgeon, very interesting you put a surgeon here. Cardiologist cannot.
Depends.
Okay, and then syncope induced by or associated with exercise. We know that a lot of vasovagal doesn't happen with exercise. So again, this also groups under unexplained fainting. All right, and then further evaluation in patients whom apparently specific cause has been established. For example, we have patients with a really have pacemaker implanted for cochlear block. The worst thing you want to have is after a pacemaker implanted, the patient faint again the next day. You cannot explain that. So then you probably suspect there is a vasovagal component apart from the patient having a cochlear block or sick sinus. Now, of course, contraindication, you don't want to tilt patients who the echo ratio that severe aortic stenosis, patient with severe mitral stenosis, or patient with a known triple vessel disease, or patient with a recent stroke. And because once the vasovagal is induced, the most common cause of vasovagal is a drop in the pressure, and you have not enough blood flow to these organs of important organs and cause a massive stroke or a massive heart attack. All right.
You get a diagnosis, but you induce a stroke.
Yes, right.
So yeah, moving on, we did the tilt table for this patient. Initial 20 minutes tilt was uneventful. In fact, the patient was getting bored and was yawning away. And then we gave, as part of the protocol, we gave the patient a puff of sublingual nitrate. 10 minutes later, something interesting happened. And again, it's not a made-up tilt table because you can see the spondylar line over here. So I want to draw your attention to this little segment. So the graph actually presents the blood pressure, and this is actually a beat-to-beat blood pressure. Means every single beat generates the pressure, and you can see that it's fairly constant. And you can see that after we have given the GTN, which is actually the blue line, there is a drastic drop of the blood pressure, and if not mistaken, this is actually lower than 50 millimeter mercury. So that is the time when the patient reproduced his fainting spell as well. In other words, he actually fainted at this point. So we have to tilt the patient down, and we can see gradually the blood pressure goes up back again. And just before the patient starts to have seizure, thankfully, he's okay after that. With total full recovery with no confusion or any kind of neurological deficit. And again, like what Dr. Goh said, if you have a patient who has a very bad cerebral artery stenosis at this point, yes, you get the diagnosis all right, but you probably induce a massive stroke in him. So a significant drop of blood pressure was seen, and this patient experienced syncope. It was promptly brought down to the supine position and regained consciousness. So this is a very important point because most of these patients actually become normal back again the moment you bring the patient back to a supine position, because the BP will come over again. So for this particular patient, there is no significant drop in the heart rate. There's no pauses seen during the syncope, and we call this the predominant vasodepressor type of a positive tilt table test. Now, why do I need to stress this thing again and again? Because there is also another type of positive tilt table, which I will probably pass to Dr. Koh to explain.
I want to add on to Choi's point there. So a lot of times when in a real vasovagal or vasodepressor type of patient, you wouldn't see a drop in the heart rate, but you wouldn't see a rise in the heart rate either. So that's how you differentiate from orthostatic or postural hypotension, where if you tilt the patient up, suddenly the pressure drops because to compensate, because the neural part is still okay, to compensate, the heart rate will actually go up. So that's to compensate to make sure there is no fainting episode in the body. But in a real vasovagal state, you wouldn't see a heart rate rise. Sometimes you can see a bit of heart rate drop, but usually there's no pauses. Now the other type, why we do a tilt table is because most of the time we know that it's vasovagal. Last time we don't even use to do tilt table test. But I will show you one of my case, my very early case. In fact, this is the first case I did tilt table. That time I had to send the patient to Ara Damansara because we don't have a tilt table here. This patient was referred by Dr. Navin at a point of time in other hospital. It's a very young lady, 30 years old. I remember after giving birth. After giving birth, she has a recurrent syncope. This is a bit unusual. The first time when I heard this story, I think, 30 years old, vasovagal, that's quite common. But the uncommon thing is, the unusual part of the history is during driving and while carrying the baby, so the patient's pain. The problem is, she pain is not like every day, it's like almost once every two weeks. So it's all the Holter, ECG, is all normal. So what happened after we put on the tilt for about 20 minutes, the patient feel a bit giddy. So I thought, most likely it's vasovagal. This is what we observed. You can see the upper strip. So these are lead 2. You can see the QRS separated. So it means that it's very bradycardic. It becomes bradycardia, and then there's no more P wave, and you see a flat line. You see a bit of jittery there. That's because the patient is starting to have seizure. And you can see there's an 8-second pause. Obviously, I panicked because she's she's like a young lady studying the heart stop. So we quickly just lie the bed flat, and then spontaneously get better. But to be honest, I personally know that most of the vasovagal, even though cardio infantry, they usually won't die. But when you're on that time, you will probably panic. So these are the things that we wanted to capture in the tilt table. Very rarely, maybe 1 out of 50 tilt, you will find this, or 1 out of 100 tilt. This is called a cardio inhibitory vasovagal response. These are the ones that need treatment, and the treatment of choice is at the moment pacemaker.
So no more symptoms after the implant.
No more symptoms after the treatment.
You can carry the baby.
Yes,
have another baby.
So yes, I answered this. Pacemaker, definitely.
So in the interest of time, maybe we could go through quickly. I think Ko has answered this already. Moving on. Okay, just one question. How would you differentiate a neurocardiogenic syncope from carotid sinus hypersensitivity? Ko.
Okay, this is something that we rarely see in the but from the history itself, you may be able to suspect this patient might have a carotid sinus hypersensitivity, a condition usually predominantly present in elderly patients, where their carotids, you can see from the history, usually by turning on neck and trying to fasten, tying a tie. Sometimes they try to, I got a patient who's trying to sidai the baju, everything, then they get fainting episode because they accidentally massaged their carotid area. So before we even proceed with the theory, we suspect that sometimes we will give a massage at the carotid area. Of course, you have to make sure there's no carotid stenosis. Listen with the stethoscope, make sure no bruise. We massage for 10 to 20 seconds. During the ECG, you can see either the pressure drop or the heart rate drop. This is almost always certain that the patient has carotid sinus hypersensitivity. That's how we differentiate. If we massage, there's no drop, then we proceed with a tilt table, and then we know that we excluded a carotid sinus hypersensitivity.
Okay, moving on. In the interest of time, maybe we would just ask very briefly, Dr. Choi, just to say what kind of advice you would give this patient, maybe hopefully in the next 2 minutes before we.
Sure. looks like we are running out of time. So Dr. Koh has highlighted the definite treatment, in fact, for the cardio inhibitory type of syncope, neurocardiogenic syncope. So what about those with the vasodepressor type? So of course, if you Google, obviously everybody can Google nowadays. You can see there's going to be a long list on how to treat. It starts from drinking enough water, keep away from alcohol because alcohol can vasodilate and that will bring your pressure down even more. I remember one patient who came to me with a classic history of fainting spell. After she had 2 glasses of wine, she walked to the toilet and before she reached the toilet, she actually collapsed. So we did a tube table and in fact it was positive and what we did was just to avoid drinking alcohol in her. I guess we can also teach the patient to identify the symptoms. So if you feel the symptoms coming on, you can probably do some maneuvers like lift your legs up or clench your thighs or muscle to push the BP up back again. And the list goes on. And of course, we talk about medications as well. Unfortunately, for this type of neurocardiogenic syncope, I don't think there's any particular drug that seems to be very effective. People have tried beta blocker. I mean, we always get asked this common question, you have these patients, young patients, probably they almost fainted because, the heart rate was low, the blood pressure is low. Why would you want to give a beta blocker in this poor patient? Doesn't make sense. Of course, the fundamentals, the theory behind it is actually very interesting because we believe that, the drop in the pressure is actually a very exaggerated and abnormal response, in fact, to a sympathetic drive that the patient experienced. So if we were to blunt the sympathetic drive to begin with, maybe we can also blunt the vagal drive. That's why some patients are being put on beta blockers with probably mixed effect. To summarize, in fact, the treatment for vasodepressor syncope, ensure adequate hydration. So you go for a badminton game, please drink enough water. Go for hiking, drink enough water. Volume, very important. Physical counter pressure maneuvers. You feel the symptoms, identify, squat, sit down. Trigger avoidance. If you know you're going to faint when you see blood, for God's sake, please try to avoid blood or needles, like me. No. Orthostatic training program. So this is interesting. Some countries, they actually do this. So we know that they know that they will faint if they stand too long, for example, or they see certain things. So they will be put on this gradual kind of tube table gradual training where they tube them longer and longer each time until the body actually gets accustomed to it. So it's like a test. So we call it a orthostatic training program. And last but not least, of course, some drugs can be tried as well. And Dr. Jaya, as the moderator.
Thank you very much, Dr. Choi. And I think now it's time for Q&A. We'll pass it back to Alan.
Yeah, the QR code there is not for points. The QR code there is to get to the Slido. So last time we had somebody saying, I can't scan for points. So they will be patient, the QR code for points will come later. So this is just some question. There's one here. Is there tachycardia of unknown cause? How to evaluate and treat? From Dr. Ahmad Hussain.
Ko, you like to take this? You answer this now.
Oh, yes. Obviously, the first thing is depends how thorough the investigation has been done. So you just have an ECG and echo and both normal and you say is unknown, then probably not right lah. I'll probably have to, as we discussed earlier, we need to do various tests. We need to have a stress ECG. We need to have a Holter. Sometimes we have to do a cardiac MRI to make sure there's no fibrosis in the heart. Now, let's say the ECG are very typical. I already mentioned to you, some of the ECG of a PVC or DP are very typical of certain idiopathic DP. That's number one. Number two, there's no structural heart abnormalities. These are the groups, we call it the idiopathic ventricular tachycardia. Basically, unknown cause because they are arises from the normal structural tissue. For example, like the testicles of the left ventricle, they're coming from the pectoral muscle, they're coming from the alveoli area. We don't know, unknown. So these are the groups where we call it the idiopathic disease. My phone didn't have a syncope like that. So Troy, you want to add anything?
Yeah, I totally agree with Dr. Koh. So I guess the most important thing is like catching the mouse. I always tell the patient. So if you have some kind of tachycardia, if you can't catch it, you can't treat it. So either we put them on some long halter or some kind of monitoring, or if we can't, then if the patient is very symptomatic, then we have to provoke the heart, like doing an electrophysiology study and see what is actually the real tachycardia behind it.
And two more questions from Dr. Luke Lim. Why are some of the descending arm of the PVCs not slightly different from others?
I'm waiting for someone to ask this.
Sorry, you want to answer that?
Sure.
Since you're waiting for this question.
Yeah. Alan, can we switch back to my...
Yes.
So, if I'm mistaken, if I get your question right, your question is about the PVCs, right? Why some of the PVCs are not and some are not. Okay. So I guess we have the next EP guy coming in. So the morphology of the PVC depends on the origin of the PVC and also the exit of the PVC. So the PVC can come from one spot within the outflow tract muscle, the myocardium, but depending on where it exits. For example, if it exits a little bit more to the left or to the right, then the ECG that you see, the morphology of the PVC of the ECG can be slightly different, very subtle. So for example, you see this bit is very smooth on the way up and smooth on the way down, whereas this has a little notch. So it could either be, these are two different origins, very closely related, but very different. You need to ablate them separately. Or it could be even from one single focus, but just exit out very differently. Sometimes a bit more to the right, through the myocardium, a bit more to the left. So that is why the morphology looks different. Nevertheless, it is still outflow tract because both also shows positive on lead 2, 3, and AVF. They are very similar. It's just a little notch. But a little notch can make our life very miserable, right?
So most of the time, it's still a single focus. What Troy mentioned is, whatever you see in the ECG is a ventricular depolarization. Means that whenever it captures the ventricle, you can see the ECG. The point source you only can see when you do an ECG study. So what happens from the point source, it comes up on the heart and it goes left and right. Imagine I just go left and right and capture the whole ventricle. And some PVC maybe go a bit more right than the left. That's why you see the notch there and slight variation. But most of the time it still come from a single source. But obviously, the nightmare is when it comes from two different sources and very nearby to each other and you cannot catch them. So that's probably one of the reasons why the PVC are different, slightly different from others.
One more question from Luke. Will there be some permanent ECG changes after radiofrequency ablation causing confusion in the ECG interpretation?
All right. So yes, that is a very valid question actually. It's not uncommon, although I would say preferably no. Depends on where we are ablating. So for instance, the commonest problem that you might get is actually right bundle branch block. Some of the foci that we burn or the catheters that we use to move around the right ventricle, the right bundle is actually very easily, I would say traumatized, not burned or damaged, but traumatized. So sometimes if you burn too close to the right bundle, yes, you may get a bit of right bundle branch block, whether it's transient or permanently, or even not burning around the right bundle, but you can get a bit of a knock. So a couple of days of right bundle branch is totally normal, and most of the time the patient will recover. Of course, if you talk about AV nodal block, it's possible. If you ablate somewhere near the hip or somewhere very dangerous, then the patient will end up having complete heart block. But again, I guess nowadays with the technologies that we have, the parameters that we use to monitor, I guess the odds of it happening is very low.
I think the incident even before the era of 3D mapping is about 1 out of maybe 200, so 0.5% that we have cases of cochlear block. So, and also another way to answer your question, will there be some permanent ECG changes after RF ablation? Of course, yes. Means that after you see a PVC, after we ablate, no more PVC. Permanent ECG changes. AF, we ablate AF, no more AF, permanent ECG changes. So it will cause a confusion.
Yeah. And one more.
We expect the result.
Correct. The best example is the patients with Wolff Parkinson White.
Yes.
I always tell the patient, yes, you will have very different ECG after this. It is called a normal ECG.
one more question there. From Dr. Chung. PVC are usually considered benign, especially in frequent and asymptomatic. Would we need to do further investigation for them if asymptomatic, i.e. incidental?
Okay, this is very interesting. So PVC are usually considered benign. Yes, maybe 20 years ago. This is, I always tell the patient and my fellow colleagues, PVC is something like hypertension or diabetes. You are diagnosed with hypertension and diabetes, your BP is 150, 90. You won't die immediately. You won't get complication tomorrow, even in 1 year or 2 years' time. But you don't have symptoms. I have diabetes, but I don't have symptoms. I have high BP, I don't have symptoms. Can you leave it alone? You can, but you have to bear with the consequences after many years. So this is what end up with us. Why we view PVCs so seriously is because those who have been treated conservatively over many years, of course not all, I'll say, let's say 100 PVC, especially high burden, if you leave it alone, after the course of 10 years, maybe about 20% will probably come with either a heart failure, the LV will dilate, the EF will block, or come with atrial fibrillation. And these are the conditions that is more difficult to treat because remember, Troy, when we catch all the PVC very early, our aim actually is cure.
Yes.
Now, when you catch it at a very early stage, like for example, a PVC-induced cardiomyopathy, PVC-induced heart failure, we are probably still talking about cure, but sometimes we only can end up with palliative, meaning that we're able to stop the PVC, but sometimes the heart function is not back to normal, or the patient already developed into chronic atrial fibrillation. Very difficult to revert back to normal.
When would you consider a high PVC burden as to, for example, Troy's patient was 30%.
So in general, consensus and guideline-wise, if you have a 24-hour Holter showing that the PVC burden is more than 15,000, 15%. 15% means that in a day you probably have 10 to 15,000 PVC in a day. That will probably consider high burden. Even though asymptomatic, you need further evaluation and consider radiofrequency ablation or medical therapy. The medical therapy is something like we give even more effective one like flecainide or sotalol in combination with beta blockers.
What if it is just about 5%?
Monitor. So it's like diabetes, HbA1c 6.6 or 6.5. Sometimes you don't give treatment, but doesn't mean that you can ignore it. Monitor, always monitor.
Like me,
yes, correct.
Apple Watch and monitor my ECG. I have a PVC burden.
Yes, a lot of monitors like watch. Dr. Alan just showed me the new watch. Very, very, very cocky guy. The ECG, the Apple Watch able to detect rhythm. But of course, you need to have a special programming for that. And I'm not too sure, Alan, whether they can record the burden or not over 24 hours.
No, it's only a very short time.
I'm sure that one day they were able to record the burden, meaning that they will calculate beat to beat and normal, and then they will differentiate. They will have an algorithm to differentiate normal beat and a PVC beat. And then everybody can monitor their burden on their watch.
In the interest of time, maybe it's time for us to, don't forget the QR code.
Okay, guys, time to get your point. Thank you for staying on. The MMA events app has been fixed. Some problems with the server overloaded. So MMA has kindly paid more money and upgraded the server. So you should not have the spinning wheel when you're trying to scan the code or log into the MMA app. Yeah. It works.
Yes, it do. Yeah. So thank you very much for joining. And I think Dr. Allen will leave this QR code on for a little while, and we will keep the studio. Thank you. Please, our next SJMC Grand Round, number 6, will be on the 6th of February. Thank you. Please join us then.
We can end the broadcast, but the video is there for you to play. Those of you who come late, you can still watch it again, or you missed the beginning, you can play back. That's the nice thing about streaming. The video is there for you to refer to. Great session, guys. All right, good afternoon.
Thank you.
Thank you. So we can exit now.
Ending broadcast.